Hello everybody and welcome to this lecture. Today the title of the lecture will be All Ceramic Restorations, and I'm sure that is very interesting topic for everybody. We will try to discuss especially the use on extensive rehabilitation cases. So let me start saying that of course the criteria selection will be very important. And to have a nice criteria selection, of course, we need to know a little bit of the properties and the feature of the material. First of all, I believe that today we have two materials that are really the king in this market. The two materials are lithium disilicate on one side and the zirconium on the other side. But let me understand exactly what is the difference between the two materials. First of all, we have the silica-based material, that is the lithium disilicate material, for example, or Empress material, like that they are glass ceramic material, and together with the feldspathic porcelain, they are in the family of silica based because we have the content on silica that is quite high. What is the main feature of this material? The main feature is for sure the translucency. Better to say, the light transmission property of this material that is very, very nice, similar to that of enamel and dentin. So, what are the characteristics? What you can do with this material? We can do single restorations normally, even on posterior areas, but there is some limitation to do any kind of bridges because the strength is not so high, even though the company say that you can have some anterior bridges, but it's very limited to 3 units bridge on anterior area with some doubts about the strength. Okay, so normally single restorations everywhere. On the other side, we have the not silica-based material, so-called also high-strength ceramics or polycrystalline materials. In this family, you can count zirconia and alumina. Especially zirconia are the one that are using today by many dentists in the world. What is the main characteristic? The strength, of course. At the same time, we have not great light transmission properties, depending on the generation of zirconia. The first generation, the original one, you have not light transmission properties similar to that of silica base. But the range of option, the range of use is much wider, because with zirconia you can use single restorations, anterior and posterior, like the silica-based material, but then you can have more option, like implant abutments, and bridges, even long span bridges up to 1 arch. So the options are much higher. But at the same time, another characteristic about the silica-based material is that they are etchable. Etchable material means that you can etch the inner surface of the ceramic with hydrofluoric acid, different timing and concentration depending on the material. And you can etch also the enamel on the tooth. You can obtain really incredible sandwich, incredible tough, strength, tough restoration that will be really very resistant. So that are the characteristics that are not possible to have in the high-strength ceramics. They are not etchable normally. So let me show you this diagram that is showing that the zirconia is over 1000 megapascal in flexural strength rate in vitro. On the other hand, the lithium disilicate is more than 400, is much less. But we are talking what? We are talking about what? We are talking about the coping thickness. So normally, we have people, we have dentists, dental technicians that like to have layering process. A layering process is obtained through the feldspathic porcelain that is applied over the coping. But the feldspathic porcelain, different from the coping is very high level. It's like more than 1000, as you could see. But look at the feldspathic porcelain. From here, you go down to here, 90 megapascal. So it means that it is much fragile, actually. And of course, you can also have the chance to have directly the ceramic coping, they becoming full anatomy, becoming monolithic material. So at this point, you have the total amount of incredible high value of zirconia, more than 1000, that is still in occlusion. That is different. You have to take less risk to have any chipping. So just to summarize what I said, with zirconia, you can see that we have an improvement on the strength. More you have the content of the crystals, that polycrystalline material, it is very tight each other, no silica in the middle, is very high resistance. Decrease much more on the lithium disilicate, on the glass ceramics namely, but look, the translucency increase much more than the other family, the zirconia. So just to explain to you that we have this kind of relationship between translucency and strength. So what to say about the possible failure of these ceramics? Because of course it is important. We should be aware about the physical properties of the material. That is a kind of little chipping that we have in the layering process. Today, I want to anticipate to you, all the posterior area in our office, we do just monolithic material, both zirconia and lithium disilicate. So in this case, it was layered, and the layering was chipping over there. But the coping that is quite strong underneath remain intact, like, for example, the metal ceramic work. Exactly the similar concept. On the other hand, you have a cross-section breakage. That is happen, of course, when you have the coping that is not so strong. And that was the first generation of alumina in the early 90s or late 80s. So actually, that is different. So strength and hardness. Strength describes the resistance of the material or component against deformation by external forces. The hardness is the surface characteristic which describes the resistance of the material component against the invasion of other objects. So that is a classic example when you have a very hard material that create a wear of the antagonist. So that's the point. And of course, we have also flexural strength and flexural toughness. Flexural strength is the maximum vertical load the material can support. The flexural toughness is the way how the material can resist on the kind of enlargement of some flow that can exist internally on the ceramic. So this way is the maximum force a material containing a flow that can happen, of course, in the ceramic, or crack can withstand without enlargement of the crack. It will be stopped. The crack. So that's the way how this kind of situation can be very positive, especially for the zirconia material that have this kind of property. Anyway, the glass ceramic must be strengthened in another way, as I already anticipated to you, by means of adhesive cementation. That will be increase the strength quite dramatically. So let me tell you about the physical property we discussed, now optical properties. Optical properties see, of course, this silica-based material to be much closer to the normal tooth, to the enamel, for example. And that is absolutely important to have the good light transmission properties that allow you to achieve the best result, aesthetically speaking. Let me give you an example. That's a case that we made a long time ago, maybe 25 years ago. We selected an Empress material because an Empress material was a very translucent one, and you see the adjacent dentition seem to be very, very translucent too. So in this case, of course, the more critical area is not where you have a lot of space, this area here, because you have a lot of space, you can achieve the best result you wanted. The best result was, the most complicated area is related to the cervical area, where the thickness of the restoration decrease up to 0 on the marginal area. If the marginal area is not so far into the sulcus, it's just 0.2, 0.3 inside. But once you finalize your case, and you position your restoration in place, you see the behavior of your restoration is more or less identical to that of the adjacent the contralateral central incisor. Why? Because you have a kind of really great interchange between the gingiva and tooth, gingiva and the natural tooth, gingival and restoration. This is a kind of blending between the two tissues, soft tissues and hard tissue. They are joined together without creating any opacity, any line, any border, just a compenetration between the two material itself. Why? Because you have a very, very, very translucent material in very, very thin thickness, becoming similar to that of the natural dentition. So identical in terms of aesthetic result. This happens only because you have a light transmission property that is perfect. So today, when you have to select the right material on all ceramic, you should understand, you should think about 4 different aspects. First of all, abutment shade. Because what we said about the lithium disilicate is great, but if you have marked discoloration underneath, it will be very complicated to cover the discoloration. So you maybe have to select one material that is more opaque, more dense, covering more, like zirconia, for example. And then the space requirement, so the clearance you have and the tooth reduction that you have to do. And of course, on posterior, for example, you need a occlusal thickness of your preparation that is quite high in order to really have the chance to resist to the occlusion pattern. So you have to reduce more the tooth. And then the translucency of adjacent teeth. You have to select the one that is close to the translucency of the adjacent dentition. And sometimes it is like the case that we have seen before, that is perfectly translucent. Other case it can be more dense, more opaque, and you can maybe have another choice. Then the strength requirements. So it means that in posterior region, you need much more resistance than anterior. So if in the anterior you can use maybe what you want, more or less, once it's etched and bonded, like a silica-based material. On posterior, maybe you can have you can see with favor the fact to really use another material that is maybe stronger. So that is more or less the system selection that you can have and the choice that you can select depending on these kind of 4 elements. So let me say, with the zirconia material, we have a different kind of reason why we use it. First of all, because there is a transformation toughening. We discussed it before. If you have any flow inside, it can be stopped by the material itself. So you have a slow crack propagation. At this point, you have a very high fracture toughness. Second is wear that seems to be really compatible with enamel, even though it's so hard, this material. So it's wear resistant. Then can be cemented. You're not obliged to bond like you have to do in the silica base. And then you can have restoration types you can use for almost everything. Because again, you can use it even for a full arch bridge. So it will be really very, very wide range of options. So let me now differentiate the advantages and disadvantages of this family. Again, we call high-strength ceramics or polycrystalline material or not silica-based material, so namely zirconia. Advantages: strength for sure, precision, mask ability, so you can cover the color that is dark maybe underneath. It can be used for long span bridges, it can be used for implant abutments, and can be used also for, it can be obtained through the CAD-CAM system, CAD-CAM processing method. In terms of disadvantages, you have a higher opacity than lithium disilicate, for example. You can have a potential wear of the antagonist, even though it seems to be not so damaging the antagonist. You can have a chipping, but we know now how to solve it. We will discuss in a while. You can have an edging effect over time. You can have the decrease of value of zirconia fracture strength rate. And one limitation is also the non-fluorescency of this material. And actually, I can tell you what can be the use of this material. Discolored dentition is one of the most important reasons why we use this. So let me introduce this case. Very dark teeth, that can say even more than dark, is black, especially the central incisor, the lower. Okay, it's very, very dark. How to fix it? We have used in this case, long time ago already, 0.3 thickness of the coping, then you layer it. So actually 0.3 is really, really very thin. You can also use 0.5. Maybe you can cover even better, but already with 0.3, with the classic zirconia material, you can cover dramatically in a proper way. Even the central incisor was really covering a lot. Look how dark was here, was really black. How you can use this with 0.3 already covering. Maybe a little bit more grayer than this, because the color here is different. That is less dark than this. So we can have some little influence on this. Not this to be grayer maybe. But then with the layer porcelain, we have a 1.5 millimeter of thickness. You can have the chance to really create the best result. So no problem at all. You can achieve nice result. 10 years later, seems to be still okay. Other kind of option, of course, is what? Of course, are implant abutment. We use today, of course, Sometimes we can also add in the abutment some metallic component to strengthen the system even more. But the abutment zirconia is quite classic, and we can use for really many cases. And of course, it's strong enough, especially on anteriors, where you need the maximum aesthetic, especially with the thin periodontal biotype, you can have the best results. You can then put over, if you like to have more translucency, again, a lithium disilicate crown, like you did in this case. So we had a combination between implant abutment in zirconia, a lithium disilicate material over that. And you can obtain quite nice result at the end, quite similar to the adjacent dentition again. So another important option, that is really something that changed completely than lithium disilicate, are bridges. And especially, that is the reason why the zirconia came out in the market, because it can substitute the metal porcelain work. That is the main reason why. And that's what happened, because today most of the dentists using these bridges in zirconia, even full mouth rehabilitation, even in long span bridges like this. So that is a case that we made 12 years ago already, and that is the situation with zirconia bridges, 3 bridges on upper arch, as you can see here. 1, 2, and 3. And that's one long span bridges in the lower arch. That's the case at the time of delivery, so long time ago, 12 years ago. And that's the case 12 years later. What is nice, not just the final X-rays 12 years later that seem to be really perfect, still the osseointegration of the implants. What I like most is that we have some little recession, but cannot be visible so much. The patient didn't realize that. But look at this. If you look carefully, you have a recession there. That is quite normal 12 years later. It's not bad, but take a look without looking at the details really in the proper way, you can really be satisfied anyway. And the patient is really so much satisfied about the final result and the long-term result at this point. So what is another limitation that we had and that we solved right now is a kind of problem of chipping of veneering porcelain. When you don't use the monolithic material but you use to layer the ceramic over, you have the problem of some chipping. And actually, we have solved this problem having the chance to prolong the cooling rate, especially with a thick framework. So what is important, of course, is matching the coefficient thermal expansion between the core and the veneering porcelain, but that is achieved. But what is more important is, again, prolongate the cooling rate, especially with a thick framework. So that is really the most important part that you want to achieve. And that is why we had the chipping, because there is a kind of residual thermal stress on this work. And that creates chipping, as you could see here. That is really a shame. So what Tan, that published in 2012 this kind of article, says is the following: slow cooling and slow heating regimes should be used when firing porcelain zirconia, but especially the cooling rate were found to be more influential than heating rates. And the failure, that's still important, was localized to porcelain adjacent to the porcelain zirconia interface, not at the interface itself. It was not a delamination. Okay, it's like a cohesive fracture. So indicating a residual stress of thermal origin within the porcelain. So that is what happened. So please try to use this in this way to avoid or to minimize at least the chipping rate. We have stopped to use zirconia for that reason, for the chipping rate very high, for some years. And then we started again, and now we have no more problem anymore, because now we found that this is changed completely our final result. There is no more any kind of residual thermal stress inside. So how to bond zirconia that is not etchable material? And the literature that you can find around can show you that you need to clean the inner part of the ceramic. Some people say not with the phosphoric acid. That is quite controversial issue. Anyway, you can roughen with the air abrasion, 50 microns of alumina, sandblasting material, and then you have to use, that's the most important difference, a kind of phosphate monomer inside the cement. You can use, you can add it, you can have inside the cement. This is called a chemical activation. chemical activation. So chemical activation that is achieved through airborne particle abrasion using 50 microns of alumina at 0.25 MPa, bonding with the phosphate monomer containing system, like in this case, like Unicem. So irrespective of the sulfate treatment, the self-adhesive, that's the cement that we're using, the self-adhesive cement. The self-adhesive resin cement perform better in terms of bond strength to yttria stabilized zirconia than the conventional resin cement. So the conventional resin cement are okay, but that containing the phosphate monomer works better. That's the point. So zirconia resin bond, we have the first generation now and the Emax. The first generation and the Emax. We had the chance to check the protocol for ceramic sulfate preparation. So we are talking about the original zirconia material, not the new modern material that we discuss in a while. So the first generation and versus the third generation and versus Emax. Protocol for ceramic sulfate preparation for zirconia. Airborne particles, as you said, 50 micro aluminum oxide, sandblast of 0.2, 0.25 megapascal, and actually with the Emax, lithium disilicate is a completely different story. You can have etch with hydrofluoric acid, 5%, for 20 seconds only, 20 seconds. That is a big recommendation. Don't be wrong. That's for, of course, lithium disilicate. So zirconia, first or third generation doesn't change the treatment of the surface, and for the Emax, you change completely this kind of procedure that is just etch with 5% of hydrofluoric acid for 20 seconds. So, what about other kind of important feature of the restorations of zirconia types? Because we said before we have a first generation, and this is 3% of molecular yttria tetragonal zirconia polycrystal, and 0.25 with the alumina oxide, with alumina sintering aid, and we have the flexural strength rate is about 1,000 to 1,500 megapascal. That is the classic original zirconia. Then we have a new zirconia material, but in the meantime, with the classic one, you could not avoid to do some layering process, even on posterior. Why? Because it's very, very dense, very, very opaque. So the patient will be not so happy. So we have always to add with some feldspathic porcelain that is 90 megapascal more or less. So that's the reason why we had chipping, a lot of chipping. Today, we had a chance to have this different kind of situation, but until you have used just the layered zirconia, of course, we can have the weakness of feldspathic porcelain that can create chipping, the weakness of zirconia porcelain bond with the lamination, even though I had not this kind of problem. The problem was a cohesive factor within the layering of porcelain. So it means within the porcelain layering. And the porcelain veneering, of course, increase the thickness for the restoration. So you have to prepare more to have the chance with the same contour to have a cupping underneath, pure layering porcelain over. So that is the reason why the company that produced zirconia have started to found new kind of material. For example, the second generation of zirconia that is still 3 molecules of yttria, but at the same time they decrease the quantity and the content of alumina. At this point, we have the chance to have less strength, that is become around 900 to 1300 megapascal with some less opacity. But the big transformation is today with the first generation of zirconia, with the 4 or 5 molecules of yttria, is also called cubic zirconia, is 25 to 50% on and more of a cubic phase. It does create a flexural strength that is different from 400 to 1000 megapascal. Today we have a different brand of zirconia that are really working on this field, on the third generation of zirconia, on cubic zirconia. It's also interesting because this kind of translucency that was achieved in a better way with this kind of cubic zirconia is normally characterized by the grain size. You have no vitreous phase, not content of silica inside to have more translucency, to achieve more translucency. It's just the difference in the content of the zirconia material, but not a vitreous phase was added at all. You can see here different brand, different name, but more or less today every company are working on cubic zirconia with various denomination by the grade of translucency, but more important, depending on the brand, they use different terms like super translucency, ultra translucency, extra translucent. Anyway, just to indicate how much can improve the translucency of this material, we use the Katana zirconia. The UTML is the ultra translucent multilayered. You can use these on anteriors with 450 megapascal flexural strength. Then the STML is about 750. It can be used for posterior restorations, single restoration, and from 3 units bridge. Also for the bridge, 3 unit bridge is possible. ML with the IT translucency, it will be the 1200 megapascal. It can be used for even one arch. So that is more or less what are the indications. But normally, today we use the ultra translucent anterior monolithic single crown or veneers, or you can also layer, of course, and super translucent posterior. So ultra translucent anterior was about 450. Super translucent posterior will be about 750. Can be monolithic, single crowns, or 3 unit bridge, as we said. This is the comparison between the flexural strength rate and the translucency of the two materials. The first generation of zirconia over here, that you can see is not so much translucent, the first generation. The second generation, more translucency, but less strength. And the third generation that is much more translucent. And at the same time, you can see the flexural strength rate. Also in this article here, you see the translucency of the IMAX CAD LT, that is low translucency, seem to be a little bit more translucent than Katana ultra translucency. And also on the 0.5 and 1 millimeter thickness. So what to say? With the zirconia, the company tried to achieve similar result in terms of aesthetics to the IMAX, to the IMAX CAD or to the IMAX Press, the same. But still, today we believe that the IMAX is a little bit more brighter, less opaque and more translucent than Katana UT. Not so far away, but of course a little bit more. That's at least our clinical normal way. So that is the case in which we have very dark discoloration properties that you could see here. And of course you can use the zirconia in this case more than the lithium disilicate because the darkness is quite high in some abutments. So that's the reason why I believe that maybe the zirconia can be better cover, for example, this, maybe also these cervical areas that are very, very dark. And that's the reason why in this complete full mouth rehabilitation of these the implants and natural dentition, we had the chance to finalize our work. You see again the very dark teeth around it. Implants. We have used this kind of technique with the partially layered. We maintain the lingual part, the palatal part of the upper anteriors still in monolithic material. You can still use, if I single restoration, the ultra translucent. But the back side, I would like to improve the aesthetic result, leaving some space for the layering process. And that is what happened here. We have this concavity on the back side, incisally and middle third, in this area here, you see. And that's the reason why we had the use of a layering process there to optimize the case. That will happen in the upper arch, in the lower arch at the same time. That the lingual part, all the occlusal setup on implants. So full volume zirconia on posteriors and anteriorly with some layering process. You can better see also from this picture here. You see the space that we left for the layering process. And that is, again, posteriorly, but just monolithic. Anteriorly was layered, partially layered, just on back side. We left the lingual part where you have the function, where you have the occlusion, in monolithic material to avoid any chipping. Then we have a light transition properties here, light transition division of the tooth. We can then optimize the aesthetic result on that. Almost done, ready to position the mouth. That's all the restoration in place. All zirconia, different kind of zirconia ST on the posterior 700 megapascal even with the 3-unit bridge, and UT ultra translucent on anterior with the 450 megapascal rate. That work on the model, so is everything finalized, before and after, and before and after. So let me check with you now the other family. The other family is, of course, what? The silica-based material. And we're talking normally about lithium disilicate. What about the advantages? The most important advantage is the etchability. So this material are etchable. You can bond the restoration. You can have also the choice of different translucency and opacity ingots. You can reduce the two preparation because we have a very good and natural transmission properties of this material. You can use a pressing technique, like the last wax technique, last wax technique, or even with the CAD-CAM processing method. You can use both. Normally, you have a very low wear of the antagonist. That are all the advantages. The biggest disadvantages is not possible to do bridges. If not, just very small bridges anteriorly with the eye connection, because you should have a 16 square millimeter on the connection area. So that's means that very, very few cases that you can use an anterior bridge. But you have a lower fractural strength and toughness. So you have a lower fractural toughness. As I said, inappropriate connection size in anterior bridges. So in one word, you cannot do any bridge. Posterior, but even anterior is complicated. So let me talk to you about what we call minimal invasive prosthetic procedure. Definition is a prosthetic procedure that with the aim of saving as much structure as possible, maintaining enamel for predictable bonding. That is quite classic to this kind of material with lithium disilicate or with the silica-based material, where you can etch this kind of enamel and you can have an etching porcelain over. So it's also possible to do veneers on zirconia, probably, yes, but my feeling is still to stick on this kind of material for this kind of bonding procedure. That is at least my choice. So let me give to you a kind of description of the families that we have divided, the MIPP. The classification say that we have MIPP 0. It means that is additional restoration, where you have to add maybe veneer, additional veneer, without preparing the teeth, with no prep, but in enamel, of course. And MIPP 1, like veneers, normal veneers, or posterior restoration, like only buccal-occlusal veneer, with the structural preservation mainly in enamel. So both of them, MIPP 0, MIPP 1, are described having the patient with their own occlusion. So they keep the occlusion that the patient has, is acquired occlusion. Acquired occlusion. It means maximal intercuspation position. Okay? Then you have the MIPP 2 and 3. That is another category, because in all these cases, we modify the occlusion. And we go with the patient in CR, in centric relation position. So we can divide the MIPP 2A and B. A is partial restoration like before, veneers, but in this case, we had a chance to create a kind of occlusal adjustment, probably, to put the patient in centric relation position, of course, still with enamel preservation, that is a key point. Then we have MIPP 2B, in which we have a full veneer, so an extended veneer from buccal to the lingual. In case of open bite, we have the open bite, in centric relation still, with enamel preservation. And then you have MIPP 3A and B, in which you do one arch, MIPP 3A, or two arches, MIPP 3B. So full mouth rehabilitation practically. In all these cases, of course, one arch or two arches, the MIPP 3A and B, we go anyway in a new occlusion, so in CR position. So we have lost the dental position that the patient had before grinding the teeth. When you grind it, you remove all the contact. So from dental position, you have to find an articular position. And the articular position for me is that to find the CR position. So MIPP 2 or 3 are only on CR. MIPP 0 and 1 are in existing occlusion, acquired position. So I remember you that we discussed before about the etchability of the ceramic. I told you that we have to use in lithium disilicate 20 seconds only on the 4.5 or 5% of hydrofluoric acid. That is what you have to do, 20 seconds. Then you put silent, of course, and then you bond it. So MIPP 0 is a classic case in which you want to do what? You want to do, of course, orthodontics. But she's young, on the 20s. She wants to improve it. She wants not having this lateral incisor so less representative. And we did this kind of this kind of additional veneer. Seems to be really big, huge, but the patient doesn't feel it that is so big. Why? Because we had already lingual part in this position, and the buccal part was between the central incisor and the cuspid that were already more out than the lateral. So she cannot feel with the lip anything wrong. Seems to be crazy. It is crazy. Sometimes it's a kind of course, it's not the normal regular case. A compromise solution, of course, but that is still possible. If you achieve this result, the patient will be great. And she'll be very happy to really going around with a new smile, with no prep. You did something nice for the lady. But of course, normally we prepare the teeth. And of course, in the preparation design, we have the key element. What is the key element? Keeping as much enamel as possible. On the facial preparation, but everywhere. So, keep as much enamel as possible. Even you prepare, seems to be a crown. Actually, not a crown. At least the design is a kind of crown, but the fact that you have enamel 100% on the back side, as you can see from the whitish sharp face appearance, but also on the lingual, because you have an open bite, for example, you have the chance to say that is great because it is complete in enamel. Enamel preservation is a key point in every case. If you have to prepare, in MIPP 0 you have not prepared. In MIPP 1 you keep the occlusion as it is because it is a nice position, but then you prepare for veneer. Even though you open the interproximal area, you can keep enamel 100%, as you see here. So what about the conventional versus innovative preparation? Depends on different factors. The amount of configuration of existing tooth preparation. If you have an old case, you have removed an old restoration, of course you cannot avoid to do conventional. Then the amount and configuration of tooth structure. Again, if you have a very big devitalized teeth with a big composite, you cannot avoid to do this kind of very traditional preparation. The type of restorative material that you select, if your selection, for example, is metal ceramic work, you cannot avoid to do this kind of traditional preparation. And then, last but not least, the design of prosthetic solution and the clinician's training and experience. Yes, because to do innovative, to prepare innovative way, if you have traditionally prepared in all your life the conventional type of preparation, will be more complicated and will be different. So when conventional, or when we use the innovative? When conventional, when you have the presence of already traditional preparation. As I said, I remove the crown, I see that there is already a preparation made in a special way, in traditional way. Not special, in the traditional way, conventional way, with big shoulder, maybe big chamfer. And then, if you have to use the porcelain fused to metal, as we said, when you have to do bridge, if you have to do bridge, it's very complicated to have a good parallelism without touching and inclining more the axial walls. At this point, you remove the enamel and you become to really close to become just dentin. At this point, you have to say, I did a conventional preparation. And then when you have a marked discoloration, for two reasons. First of all, because if you have marked discoloration, normally you have a devitalized tooth underneath. Secondly, because it's want to cover something that is very dark underneath, you have to gain some thickness of the restoration. And thickness restoration means that you prepare much more. And that is unavoidable. Once you want to be innovative, I want to become less invasive as possible if I have to start a new preparation, saving as much enamel as possible, and then having the chance to bond the restoration, being complete or partial coverage, it doesn't matter. You have to really bond the restoration in a proper way, keeping as much enamel as possible. And just to have an idea how much enamel you can have normally in central incisor of the upper arch, there is a new article, very traditional article by my friend Marco Ferrari that have measured the enamel thickness in relation to reduction for etched laminate veneers. You see the gingival area, 0.3044 of thickness, middle 0.6, incisal 1.1. So it means that you have progressively more enamel from cervical to incisal, and according to that you should do the preparation according to this, of course. Today we prepare very minimal, we said. Thanks to the material is very strong, even in very thin thickness, you have a very good, reliable, and predictable final result on the veneers area. Then you have to select different kind of technique. For example, you want to be supragingival because the material itself works so well aesthetically that you can achieve this result, aesthetic result, even though you have not prepared underneath the gingiva. That's an option. And that's the supragingival margin. That, of course, has big advantages. First of all, the presence of enamel, even on the cervical area. So perfect. Even though this cervical area can be not natural prisms, but the prismatic enamel arrive up to 1 millimeter close to the CEJ. But you have a supragingival of 1 or 2 millimeter, you have a very great presence of the enamel and the prisms of the enamel. So presence of enamel is one point. Second point, easy to preparation impression taking. You don't have to put any cord inside to take an impression. It's easy visible. And then effective control of marginal fit. So you can check exactly if the fit is perfect or not because it's supragingival. And last but not least, you don't create any problem on the gingival outer line. So ideal periodontal response because you are far away from the gingival area. And the easy bonding procedure. You can put your rubber dam, like in this case, and bond perfectly in a proper way. Then sometimes you need to hide your restoration. You want to go intracircular with your margin. And of course, have some advantages, some disadvantages. So you can change the shape of the tooth because being inside the sulcus, you can have the emergent profile that can be changed. You can close some interdental spaces if you have some diastema. You can cover discoloration, especially interproximally. You can cover exposed dentin, always interproximally, and cover composite filling. I think about the interproximal area because many times you have some composite in between them. That's the reason why you can comprehend your, confine your restoration over the old composite that have to be redone. Then another important area on preparation on these veneers, buccal veneers, are the contact area. You want to keep it or want to open it. That's the point. Of course, if you maintain it, you can have a more sound tooth structure. You can have the tooth position stability. You can have these teeth that are not moving, not possible to move because they are touching each other, they are in contact interproximally. You have tooth structure maintenance that is, of course, maintained because you have maintained interproximal area. But at the same time, if you not maintain, can have some advantages. Modification of tooth shape and contour. Let me give an example. We want to have a dominant central incisors. Dominant central incisors, you can have the chance, once you that you have opened it, to increase the width of the central incisors, also maybe the length, so the total proportion, and decrease maybe the importance of the lateral incisor, just to give an example. So modification of tooth shape and contour is very possible. And then you can eliminate interproximal defect or composite, as we said before in the previous case. And then aesthetic optimization, again, because you can change shape and contour predictably. And what else about preparation on veneers anteriorly? That we have two different kinds of solution. One is called overlapped, the other one is called incisal shoulder or butt joint. It means that in this case, your margin will be designed more or less like that. Not going back to the lingual part or the palatal part, like in this case, that is called overlapped. So this is the butt joint preparation with the internal part of the butt joint that is longer than the buccal one. So the palatal one is longer than the buccal one, in order to facilitate even this kind of horizontal insertion. Horizontal insertion, but you can also have three-quarter insertion, also prosthetic insertion, like this. But this one is the only one possible with overlap. It's similar to the crown, path of insertion. In this incisal shoulder or butt joint is much easier, and you can achieve the same result of path of insertion with different inclination. It's easier. And then, of course, the isolation. When you bond, the restoration is absolutely important. So we have the key element to have enamel, of course, but at the same time to isolate one by one the tooth that you want to bonded, or even having the chance to isolate from area to area, from cuspid to cuspid, for example, and maybe to put sometimes a cord inside to entrap the cement excess that sometimes is very, very tough to be seen because it's very translucent, the cement excess going into the sulcus. So sometimes it's important to put some cord inside to entrap this kind of cement excess. And that is MIPP1. It means a veneer. That is a very easy, a simple veneer that you can do in this case to optimize the case and removing and avoiding the diastema. Also in this case, you want to change the lateral incisors that are very, very small. Also the central incisors are quite not so important. We want to give more importance on that. We prepare the teeth slightly on enamel 100% with MIPP1, and we can finalize with delivery of the case. This middle-aged man was happy about the final result with more lateral, with more view of the center and the lateral that are much more evident than before. That delivery, this case was at delivery, and then that was after a few years in service. And we see that we enlarged the size of the central and also of the lateral. So now we're going to the MIPP2, A and B. In the MIPP2, A and B, we are changing the occlusion. We have put the patient in CR position. So they are partial restoration, still veneers, for example, but after having done a kind of occlusal adjustment. Why? Because we try to calculate all the time aesthetic and function. What to say? In this case, we have the patient that was sliding a lot. We have a big interferences, so a prematurity in this case. And we had the chance to do some occlusal adjustment, tiny bit, in order to improve the final outcome on occlusion, because we had attrition before on anterior area, so we want to avoid any kind of problem. We want to put the patient in CR, and now it's going much better, and the patient was saying that it was working well.
That was so much before.
Yeah, so you couldn't realize that it was bad before, but now, once it's done, you understand that it's much better. Good. Good. So just to say, in this case, the occlusal adjustment was done, and then the veneers were finalized with the more effective way, because we believe that at this point the veneer can be really optimized 100% in terms of long-term result, because we check the occlusion. Maybe we have no more slide like before, no overload on a single tooth, but just dissipating the load everywhere. So we did the mock-up at first, and then we cut back with the calibrated reduction, and we have now the teeth that are free of mock-up on the two central incisors. You see how much you have cutted, almost nothing. We are completely enamel 100%. Once you now prepare the teeth, we have the 4 teeth with the full of enamel, with the prosthetic finalization that see also the 2 implants and the 2 abutments on the lateral incisor, in which we have done, of course, zirconia abutment, plus 2 crown on lithium disilicate, plus 4 veneers on lithium disilicate too. So lithium disilicate is the all restorations, the 60 restoration, even though 2 are on implants, where you have the implant abutment in zirconia. So you can see this mix that is very often is possible to do, to cement the proper way and to bond the proper way all restorations. So we put some layering process on the incisal third, as you could see, to have much more kind of effects inside. That is the 2 implants in place, the abutments on zirconia, and the 6 restorations again on lithium disilicate, as you could see here, with a very nice result thanks to the ability of Giancarlo Barducci, our technician. Then you have the MIPP2B, in which we still have the chance to put the patient in CR, but we will have an open bite at the end, and we have to extend our veneer on the lingual part, creating the so-called full veneers. That is, again, a kind of crown design, but nothing to do with the crown when you prepare the teeth, because you have a space between the upper and the lower, so the upper part, the palatal part of the upper teeth, anteriorly, will be in some way strengthened by the position of the full veneer that create a kind of new thickness in the space that was open at this point between upper and lower. So at this point you can put some new layer because you have extended the veneer from buccal to lingual. And the lingual part, again, you have a new thickness, maybe 1 or 1.5 millimeter, and that is called this entire restoration, the full veneer. Again, is a kind of, let me go back one, maybe you can see from this picture too, is a kind of crown design, but with a thin thickness, of course, but it's completely in enamel. So aesthetic function also in this case. This lady was complaining about the fact that it was not a nice teeth size, different level of the gingiva, problem on the lateral incisor on the right side. So we want to change the shape and contour, but before that we try after ortho treatment. There was a big slide. You want to optimize the occlusion before doing any kind of restoration. In this kind of situation, we believe that it's very risky to do veneers, simply veneers. You can break it very easily because the occlusion is not perfect at all. So you want to, before, optimize the function and then finalize our case prosthetically. So we did some occlusal adjustment even in this case, but different than before, where the previous patient was able to achieve good result, good occlusion at the end. In this case, we had this open bite. Being this open bite present there, we want to have the different situation. Look at the open bite. So you have already space to really have this kind of finalization, extending our buccal veneer, that was the meaning or the request of the patient, to the lingual. Look at the space. And then to optimize the contact, light contact on anteriors. That is the starting point of the anterior guidance. So, again, let me give you this example. We are prepared on the thickness of the enamel. We are far away from the red line, dotted line, indicating the border between dentin and enamel. And then we didn't prepare at all the lingual part of enamel. We just added an extra part. It means that we have achieved this full veneer because we had the chance to have the 100% of enamel and an etchable porcelain that has to position over. And that, of course, the selection of the silica-based material is absolutely a must because you can bond it. Being an enamel 100% or approximately 100% will be very, very strong, very, very strong final outcome. So if you look at this, you have from 0.8 to 0.2 interproximally, but being an enamel 100% will be not any kind of risk, will be very resistant. So, veneers or full veneers. We started to do veneers according to the request of the patient, but then we changed it. We did the veneers preparation from the back side, completely enamel 100%, but then the lingual part was not even touched. Not even touched, because you have a lot of space present before, as you've seen. So we do the full veneers. Full veneers, completely the veneers. And you can see that the technician was able to arrive up to the margin. It's not a must. We can also stop on the cingulum. If you have this kind of cervical area on the palatal area, the cervical area is maybe in undercut sometimes, so you can stop on the cingulum. In this case, we were not undercut. We had the chance to do the full veneer, and you can see the pressing technique is completely there. And that was the beginning. That was the change of shape. Lateral incisor, right side was put an implant, a mucogingival improvement that was quite impressive. And that was also the function of the patient, moving easily right and left, having the chance to see that we have obtained nice kind of final outcome in terms of also function, not just aesthetic. With a simple veneer, without having put any full veneer, just with a simple veneer back aside, will be not possible to achieve this kind of result of function. And that's the aesthetic after 5 years in service. Let me go now to MAPP3. Remember that the MAPP3A describe when you do just one arch, complete one arch. Of course, we go in CR. MAPP3B is when you go and finalize the case with 2 arches. I call this MAPP3 concept as a prosthetic revolution. And I can say to you that we have 12 years of experience on that. And one of the first cases that we added are these, 6 syndrome. Look how much is the destruction of the teeth. They are destroyed completely. A lot of dentin, but still some enamel interproximally, as you could see here, for example. Some enamel in between the teeth. Quite big space of, quite big thickness of enamel. Not here, but here, yes. And you have to say that also lingually, you have quite a lot of enamel. So, first of all, why would I like to increase the video if that is the request of your dentist? You want to increase the video to have space for restorative material. I don't want to cut even more the teeth that are, the bottom that are already very, very aggressively treated by the nature, unfortunately. And why I want to increase the video? Also because I want to rectify the relationship between upper and lowers from the functional point of view and also for the aesthetic point of view. I can optimize the aesthetic and the function, increasing the height between the two arches, having the space in between. And then minimize, or better to say, avoid any endodontic treatment, if we could, and any post-encore, any surgical crown lengthening procedure to have more tooth available. That is our goal, of course. So we increase the video approximately 3.5 millimeter posteriorly, and automatically anterior become like maybe 1.7, 1.8 on the last molar, and 3.5 anteriorly. So it will be, of course, different from this part on the frontal area to the lingual area, to the back area. We tested the new video with the mock-up, and once the mock-up was finalized, we see that we have increased 3 millimeter the video. We optimize the function and the prosthetic occlusion setup that was absolutely achieved before finalizing the case. So that's the mock-up tested. And once you have tested this mock-up and you know that you can go ahead, you have to consider 3 important factors, because our goal is always that to maintain a tooth structure. And of course, we want to increase the video, as I said, for our need in order to minimize the aggressiveness to the teeth that are already destroyed by the nature again. So increase the video is a must in this situation here. And reduce the ceramic thickness is possible to use the monolithic ceramic on posterior. That can be reduced ceramic thickness. At the same time, you should preserve as much enamel as possible, even in this case, to have at the end the bonding procedure made. So when you change the video 3 millimeter anteriorly, you have more or less 1.6 on the last molar, on the worst situation, worst condition, the second molar. So let me say, that is the increased video. Increased video can allow you to really achieve this result. It's about 1.5 if you have increased more or less 3 millimeter anteriorly. 1.5 millimeter. You see in this case a perfect intact tooth, a molar. But of course you know that that is not so often found in nature. The intact thickness of enamel will be really very difficult to find it. So let me show you. If you prepare 1.5, we practically, if you don't increase the video, you destroy completely all the enamel. But if you increase the video, you can still have some enamel if you start with the teeth that are completely healthy, completely intact. But unfortunately, never like that. You start always with the reduced thickness of the enamel. So even 1.5 millimeter at the increased video will create some damage. You can create some problem in cutting back, in cutting away some enamel, the remaining enamel. What is the key point is very easy. If you believe that your monolithic material, lithium disilicate, can even be reduced in terms of thickness on about 0.8, that is absolutely possible. At this point, you have the chance to see that 0.8 with 0.8 gives to you this kind of amount, the exact amount that you have here, including the video. So you don't have to prepare the teeth. So if you have just a few part of enamel, not a big enamel, but just reduced enamel, you can avoid to cut, because you can put in 1.6 thickness between the two arches at this point, or 1.5 as you like it. You have the chance to avoid any preparation. You just maybe refine a tiny bit, but you have already the thickness already there through the increase of video and through the reducing thickness of your restoration. That shouldn't be 1.5 millimeter as normally believed by every textbook or every leaflet. Okay? Then you don't need. Today we can have a monolithic material quite strong. 0.8 is really enough already. Plus, if you have enamel, it will be just great. in comparison to remove the enamel to have 1.5, then you have completely indented. So you don't need to be so aggressive. You can keep as it is. 0.8 per thickness per arch will be just great on the second molar. If you especially keep enamel, of course, if you have a completely dentin, it changes completely. If you have just dentin, 0.8 can be maybe not ideal. I'm talking if you 0.8 thickness, will have still some enamel maintenance. That's the important. So in this case, you untouched enamel, that's the situation. If you have some enamel you have not touched at all, you just refine a tiny bit, you don't really grind the tooth, you just refine with a fine burr without cutting away. Then on anterior you can have it anterior layered or posteriorly stained. As you say, today many authors say that you can go underneath 0.8 easily, 0.5, depending on the enamel thickness. If you have a complete enamel there, 100% of enamel, it can be even 0.3. I will not take any risk. If you have 50% of enamel, you can have 0.6, 0.7. So it will be, something that you have to really train yourself to check your thickness and see what happened in your data. In our data, we have a very, very few problems, and the percentage of success and the survival rate is around 97-98% among 1,000 restorations. We have published next this kind of data. So enamel preservation, great. We have built up the composite on the area where we have dentin, because we have the concavity where we have all the dentin. So now we have put some composite. We have built up the composite there, and now we have prepared just tiny bit, keeping, for example, all the anatomy that the patient had still there on the occlusion. They explain to you that that is possible only if you increase the VDO and will not touch the occlusal surface, just refining, not cutting back, not grinding in the regular way. So we had 28 restorations in place. Now we have on posterior area monolithic material. On anterior is partially layered, as you have seen already, in the back side, both upper and lower arch. And that is before and after. What is the most important and impressive picture is this one. We were able to keep the vitality of the 28 restoration. No one was devitalized. And that is really something that the patient deserves, having this kind of problem. And you see that is perfect there. Occlusal stability, disclusion of posterior teeth through the anterior guidance, aesthetic improvement, right side, left side. But what is more important is 11 years after. 11 years after, if you check the x-rays, you can see this is identical, not a problem at all. Still all teeth vital, 100%. Look, delivery 11 years after. Follow-up, still perfect. Upper and lower. So means that the choice that we have done in this case was a nice choice. Delivery 11 years after. You have just tiny bit of recession on the central incisor, right one. But being 11 years after, I believe that's still very good. So just to summarize what we said, today we have in the market two great material with a different characteristic. One silica-based material, etchable, with a very good characteristic in aesthetics, especially on anterior area. The other one, zirconia, that are much stronger, and much more possible to be used in different ways, even for full arch bridges, for implant abutment, and for single restoration. So are different. You don't have to choose one of the two. You have to choose the one that you believe that is the best one for this specific case that you have in front of you. Even the same patient, you can use different material depending on the area, depending on the abutment underneath, the color discoloration, or maybe the still presence of enamel. That is what we have learned already. If you have enamel, of course, my preference is to use silica base as lithium disilicate, for example, to be bond restoration in place. That guarantees me the best result with MAPP3 that you have seen already in extensive rehabilitation. But if you have very much discoloration, devitalized tooth, of course, you can use zirconia. So with both, you can cover all clinical cases you wanted. Even in the same case, you can differentiate tooth by tooth, the right solution of restorative material. I hope that you enjoy my lecture. We keep in touch. Ciao.